This explainer is based on Anxiety-Related Dizziness of the Vestibular Physician's Deep Review of Panic Disorder, Generalized Anxiety, and Hyperventilation Syndrome, published by Australian Dizziness Clinics. Welcome to this explainer. If you're a vestibular physician, a neuro-otologist, an advanced ENT trainee, or a senior vestibular physiotherapist, you already know the reality on the ground. Anxiety and dizziness travel together way more often than our traditional medical textbooks care to admit. In pure otology or pure psychiatry, sure, they're neatly separated. But in our world, expert vestibular practice, they overlap, intertwine, and absolutely amplify one another. So let's dive right in, because today we're setting the scene to fundamentally understand the vestibular anxiety problem. Section 1. The vestibular anxiety problem, the hidden epidemic. We've all had that familiar heart sink moment in the clinic, right? A chronically dizzy patient walks in, totally over-investigated, carrying a massive folder of completely normal scans. But I want you to consider this number. 30%. Up to 30% of all patients attending a dizziness clinic have a significant anxiety disorder. We aren't talking about some rare fringe presentation here. This is a core demographic of the chronically dizzy population. Honestly, if we aren't actively looking for the anxiety component, we're just missing the complete picture. And this specific problem is highly concentrated right in our specialist clinics. Think about it. While the lifetime prevalence of panic disorder in the general population sits somewhere between 2 and 5%, in dizziness referral populations, that rate absolutely skyrockets. We're looking at between 10 and 30%. Panic disorder is literally 2 to 3 times more common in vestibular patients. That kind of clustering isn't a coincidence. It's a massive neon sign pointing straight to a shared underlying mechanism. The data reveals a very clear bidirectional relationship. We've got this huge concentration of panic disorder and generalized anxiety disorder, or GAD, in vestibular clinics, with GAD affecting 15 to 25% of these folks. But flipping around, 65 to 80% of panic disorder patients experience dizziness as their absolute most common somatic symptom during an attack. These bidirectional numbers prove that this intersection is one of the highest yielding areas of clinical practice you can possibly focus on. Section 2. Pathophysiology, the bidirectional relationship. To actually manage this effectively, we have to move past the sheer scale of the problem and look at the underlying neurophysiological mechanisms. Because this isn't just a psychological reaction, it's a structural neurological reality. What we're dealing with is a bidirectional feedback loop, the sensitized vestibular anxiety circuit. Here's how it works. Step 1. A vestibular dysfunction occurs, even a really subtle or historical one. Step 2. The brain's fear network mounts an anxiety response. And step 3. That exact autonomic arousal directly amplifies the conscious perception of dizziness. So the vestibular issue seeds the anxiety, and the anxiety perpetually fuels the dizziness. It's a perfect self-sustaining cycle. The precise neurochemistry and physiology behind that loop are actually fascinating. When a patient is highly anxious, elevated norepinephrine literally increases the gain of the vestibulo-ocular reflex, the VOR. Their balance system actually becomes more sensitive. On top of that, anxiety-driven hyperventilation causes hypocapnia, which reduces cerebral blood flow and directly induces dizziness. Add in direct amygdala feedback modulating the excitability of the vestibular nuclei, and the picture becomes crystal clear. We have to use this precise clinical terminology with our patients to emphasize one absolute truth. These symptoms are neurophysiologically real. They are never just imagined. Section 3. 3 explanatory models. To fundamentally understand and treat these overlapping phenotypes, the literature gives us 3 really helpful explanatory frameworks. First up is the psychosomatic model. Here, the panic disorder or anxiety is the primary issue. It drives the autonomic arousal that secondarily causes the dizziness. In stark contrast, the somatopsychic model is the exact reverse. A primary structural vestibular dysfunction causes chronic instability, which then generates secondary fear, avoidance, and ultimately a brand new anxiety disorder. Same destination, entirely different starting points. Finally, we have the network alarm theory. This theory proposes an abnormally sensitized fear network, specifically the circuit connecting the amygdala, the parabrachial nucleus, and the locus coeruleus. In this model, the predisposed patient's brain starts misinterpreting entirely normal or maybe just slightly aberrant vestibular signals as severe, life-threatening bodily cues. It's essentially a false alarm system firing at full volume, generating conditioned panic responses to everyday normal movements. Section 4. A positive clinical diagnosis. Understanding these pathways initiates a massive paradigm shift in the clinic, forcing us away from some old habits. And this is perhaps the most important takeaway of this entire explainer. Anxiety-related dizziness must never be treated as a diagnosis of exclusion. Using it as a last resort label, something you just slap on a patient after you've given up and run every scan under the sun, is a deeply flawed approach that leads to massive overinvestigation. Instead, it's a positive diagnosis. It needs to be diagnosed actively by identifying DSM-5 criteria for anxiety combined with a consistent functional vestibular examination. Yes, of course we rule out structural disease, but we concurrently and actively diagnose the functional overlap.
Section 5. Changing the patient trajectory.
When we shift our diagnostic framework like this, we directly change the real-world clinical burden on the patient, because without early recognition, these folks face incredibly high dizziness handicap inventory, or DHI scores, often way higher than patients with pure structural lesions. They escalate their healthcare utilization, bouncing endlessly from specialist to specialist, and often face diagnostic delays of over 3 years. Over those years, they fall deep into avoidance behaviors. They stop driving, they avoid supermarkets, they stay away from crowds. Their world just progressively narrows, and that isolation only reinforces the illness. Which brings us to a vital clinical pearl. Validating the mechanism to the patient is a therapeutic act, not a concession. By explaining the exact neurophysiology we just covered, the VOR gain, the adrenaline, those feedback loops, you're telling the patient that you actually believe them. You're reminding yourself, the clinician, that explaining the neurophysiologically real nature of their dizziness is the absolutely crucial first step in their treatment. It removes the stigma, and it sets the perfect stage for targeted rehabilitation. So if up to 30% of your waiting room is trapped in this neurophysiological loop, the big question is, how many patient trajectories could you change tomorrow just by validating their symptoms today? Join me in Audio 2 Neuroanatomy and the Vestibular Anxiety Circuit, where we follow the signal from the labyrinth into the fear network. For additional resources, including the full literature review, clinical cheat sheet, and patient leaflet, visit AustralianDizzinessClinics.com. Please subscribe to support the channel.